Good afternoon. I call this hearing to order. Pursuant to Committee Rule 4 and House Rule 11, Clause 2, the Chair may postpone further proceedings today, and without objection, the Chair is authorized to declare recess at any time. Today's joint hearing of the House Veterans Affairs Subcommittees on Oversight and Investigations and Health will examine community providers' experiences with the ongoing transition from VA's legacy community care programs and contractors to VA's new Mission Act Community Care Program and its new Community Care Network contractors. In recent months, community providers have been contacting congressional offices, including my own in New Hampshire, to express serious concerns about significant delays in obtaining payments from VA's contractors. We've heard about administrative burdens associated with resolving outstanding claims, difficulties in being added to the contractors' networks and VA's provider directories, and sudden and dramatic cuts to payment rates for certain types of care, particularly dental and home health care. In some extreme cases, local health care providers have simply stopped seeing veterans altogether because the financial and administrative burdens are too onerous. It's unacceptable that community partners would be forced to stop providing care to veterans because of bureaucratic errors or process problems with transitioning from legacy infrastructure. These issues are happening during the ongoing transition from the third-party administrators that helped operate the Veterans Choice Program to the new third-party administrators that will help operate VA's new Mission Act Community Care Program. With any transition, a certain number of bumps in the road can be expected. However, this is more than just a bump, and we've been traveling this road for a long time, and we need to see some significant improvement. Community providers simply cannot afford to continue treating veterans without being reimbursed for those services in a timely fashion, and veterans simply cannot afford to have their care delayed or halted altogether. These frustrations are not new, but the implementation of Mission Act to date has clearly not alleviated these longstanding challenges with community provider relations. In my home state of New Hampshire, community providers have now had to work with 3 different VA contractors in the past 2 years, and many are still awaiting payment for services rendered. In one case, the New Hampshire Hospital Association estimates that 23 of its hospitals are awaiting payment for nearly $137 million in claims for VA community care, the bulk of which was delivered in 2019. And yet another example, Dartmouth-Hitchcock Health System, which is my state's only academic healthcare system, estimates it currently has more than 5,200 claims, totaling more than $24 million, awaiting payment by VA's contractors, TriWest and OptumServe. Payments are not the only source of providers' frustration with VA's community care program. As you will hear from one of our witnesses today, Eric Golnick of VFR Healthcare in Manchester, New Hampshire, community providers are often bounced back and forth between VA's contractors and staff at VA medical centers when trying to figure out why contractors can't locate prior authorizations for veterans that they have treated. I'm also concerned about VA implementing and imposing what appear to be new maximum number of visits for alternative pain management care. The committee has asked VA to explain a letter that some veterans received recently, which indicates that veterans may now receive a maximum of 28 visits total per new condition for services like acupuncture, massage therapy, and chiropractic services. To date, the VA has not responded to the committee's request for more information. At a recent event in my district, I met with a group of veterans who shared with me their experiences with acupuncture. These treatments have significantly alleviated their chronic pain and in many cases eliminated their need for narcotics or other pharmacologic treatments. This small business is owned and operated by a dedicated woman named Kathy Twombly. Kathy contacted my office last August to share the hurdles she has had to navigate to provide this life-changing care to our veterans. We worked with Kathy and her medical biller to highlight some of the technical coding issues and confusing authorization forms. But the bottom line is that we shouldn't be forcing people like Kathy to struggle with a confusing payment system time after time or to jump through hoops to provide this type of life-saving care. Finally, I hope today to hear from a little bit more from VA about its new payment rates for home health care. The committee has heard recently from home health providers across the country who were taken by surprise when they began receiving payments under VA's new fee schedule for home health. In some cases, these providers are receiving dramatically lower payments for VA patients than they have in the past, seemingly without any warning. Some health agencies worry that they will have to lay off their staff or stop accepting veteran patients because of these sudden rate cuts. I would like to know more about these changes and what VA may be doing to revise its fee schedule given the effect it could have on veterans' access to home health care. Veterans who have fought for this country should not have to face another fight when they return home to get the care that they have earned. Providers who stand ready, willing, and eager to care for our soldiers when their service ends should not face a complicated and inefficient bureaucracy that forces them to lose time, money, and eventually the ability to care for veterans at all. We can do better. With that, I would like to recognize the ranking member of the Health Subcommittee, Dr. Dunn, for some opening comments.
Thank you very much, Chairman Pappas. It's a pleasure to be here with you, and also Chairwoman Brownlee and General Bergman, and all of our colleagues on the subcommittees, both of the subcommittees, Health and Oversight. Our joint appearance here is a signal of the importance of today's topic. Almost 2 years ago, in June of 2018, the Mission Act was signed into law, creating a consolidated and much improved community care program to serve our nation's veterans. And 9 months ago, on D-Day, 2019, that program went into effect. Since then, the VA has been transitioning to a new community care network, a set of contracts with new community care contractor added to Tri-West OptumServe in certain regions, including my own. If we've learned anything in the face of 2014 access and accountability crisis, it's that the Department of Veteran Affairs cannot serve the veterans alone and in a silo. Strong partnerships with high-quality clinicians in the community are critical to providing the access to care that veterans need. They're also critical to ensuring that the VA healthcare system remains strong and viable as the veteran population shifts and the delivery of care changes. Moving forward, we want to ensure that the community care networks that the VA is using are robust enough to provide the level of care that veterans are entitled to under the Mission Act. We must ensure that community care is provided in a timely manner without unnecessary bureaucratic processes that delay needed appointments. We must ensure that community care provides VA, the providers that we're partnering with are providing high quality, safe, and readily accessible care. To do this, we must ensure these providers are being appropriately reimbursed for their services, and we want to make sure that those reimbursements are timely and accurate. Those features have not always characterized the VA's community care programs in the past, which means that the VA, Optum, Tri-West, all have a lot to do to assure the veterans, the providers, the employees, and Congress that the department is on the right track. I greatly appreciated the opportunity early this week meeting with Secretary Dr. Matthews, as well as with General Horoho, former Surgeon General, and CEO of OptumServe, and Mr. McIntyre, CEO of Tri-West, earlier this week in preparation for today's hearing. The work that they're doing is not easy, but their sense of dedication to this mission is sincere, and I came away from conversations with them and also with providers, hospitals, and doctors back in my district, a very positive impression of how the Mission Act is working in our veteran communities. So I look forward to hearing this afternoon about how they're making sure the veterans are well cared for during this transition period and how the community care program that they're building may be high performance, stable, and fully compliant with the law that we all work so hard to craft. And I'm grateful to all of my colleagues who assisted on that, and also to our witnesses for being here today. And with that, Mr. Chairman, I yield back.
Thank you, Dr. Dunn. I'll now recognize Chairwoman Julia Brownlee of the Health Subcommittee for 5 minutes.
Thank you, Chairman Pappas, for agreeing to hold this timely joint hearing on VA's implementation of its new community care networks and the challenges community providers are facing as they navigate this changing landscape. Back in September, the Health Subcommittee held an oversight hearing to check in on initial implementation of this new program. At that stage, the Mission Act Community Care Program had only been operating for about 90 days, and Optum was live at just 9 sites. Here we are, 5 months later. Optum is fully deployed in Region 1 and is continuing its work to stand up Regions 2 and 3 by the end of May. I believe they are now serving about 70 VA medical centers with more to come. While your progress is to be commended, arguably now is an ideal time to reflect on potential lessons learned and how those are being translated into actionable solutions. Arguably, and this is a little bit selfish on my part, as my district is in Region 4, but I'm hopeful that veterans and providers in my district will experience the most seamless transition of all yet to come in the new CCN. I know that many members of our subcommittees haven't been in Congress long enough to remember the initial rollout of the Veterans Choice Program and all the challenges that veterans and community providers experienced during that period. I remember these all too well, and I certainly hope that VA and its contractors have applied lessons from that experience to the rollout of the CCNs. In the interest of time, wanting to have the fullest conversation possible from the witnesses, I will yield back the remainder of my time. I do, however, think it's clear from the written testimony submitted for today's hearing that we still have a way to go to improve veterans' access to care and community providers. By no means should we be declaring our mission accomplished. I look forward to our discussion, and I yield back. Thank you, Mr. Chairman.
Thank you, Chairwoman Brownlee. I'll now recognize Ranking Member Bergman of the Oversight and Investigation Subcommittee for 5 minutes.
Thank you, Chairwoman, and thank you, Chairwoman Brownlee and Chairman Pappas for holding this very important hearing. The Veterans Health Care Eligibility Reform Act of 1996 greatly expanded eligibility for VA health care when it authorized VA to provide care beyond the traditional service-connected and poor to include all other veterans to the extent appropriations were available. Since 1996, VA has seen an influx of veterans from the recent wars and additional eligibility expansions. As a result, the number of enrollees for VA healthcare has increased nearly 190% from 4.9 million veterans, representing 18% of veterans in the year 2000, to 9.2 million enrollees, representing 48% of veterans in 2019. During this period, VA has grown its in-house capacity to provide care, while at the same time relying on community care partners to augment VA care as it has for decades. As many of you will recall, in response to the Phoenix wait time scandal, Congress established the Choice Program. Since 2014, VA has consistently allocated approximately 20% of VHA's healthcare funding for community care. The remaining 80% is used to fund in-house care. The Choice Program was, however, inefficient. So during the 115th Congress, then Chairman Rowe undertook the daunting task of replacing the Choice Program and consolidating VA's patchwork of community care authorities into a single program. The result of that work was the VA Mission Act, which I was proud to support, as well as I know many of the members up here on the dais today were proud to support. And on June 6, 2019, the new community care program went live, and in the fall, VA began transitioning to CCN, Community Care Network. I appreciate the opportunity today to discuss VA's implementation of the new community care program because providers and veterans in my district have voiced concerns that the transition between Choice and the CCN contract has not been smooth. For example, in early 2019, providers began transitioning from HealthNet as the third-party administrator, or TPA, to TriWest as the bridge contract after VA elected not to renew HealthNet's contract. Around the same time, VA awarded Optum the Region 2 CCN contract, and providers who wished to continue to serve veterans were again asked to transition from TriWest to Optum as Optum built its CCN network. I understand that VA needed to fill the gap that HealthNet left, and some frustration was unavoidable. As the transition continues, it will be important to maintain high levels of communication between the network providers and the care providers. When care providers are left uninformed and unconnected to the incoming network, they are more vulnerable to transition and credentialing issues. Dr. Dunn and I had a really good conversation with Dr. Matthews on Monday, and I respect her for acknowledging the communications deficiencies. I appreciate that Optum is a new VA partner, and it will take time to iron out any wrinkles. If VA and the third-party administrator partners fail to adequately and clearly communicate with community providers, those providers will elect not to participate in the program, thereby denying veterans a care option. This risk is not unfounded, as many providers declined to participate in Choice when they were unable to get paid in a timely manner. I look forward to hearing what VA and its TPA partners have learned about the past communications deficiencies and what is being done to improve communication and provider relationships today and in the future. Turning to the veterans' perspective, I've heard from veterans in my district that they are waiting 3 to 4 months before being told whether their community care request has been approved. For veterans in my district, many of whom live in remote areas and who face bitter cold and difficult driving conditions during the wintertime, Having timely access to quality community care closer to home can mean the difference between receiving care or foregoing care. Optum is scheduled to deploy to Iron Mountain VA Medical Center on February 19th, just a week from today. I recognize that both VA and Optum have roles in the referral process, so I want to hear what improvements veterans in my district should expect as it relates to processing community care requests and when they can expect those improvements to materialize. I thank everyone and our witnesses for being here today, and I look forward to their testimony. With that, I yield back.
Thank you very much, General Bergman. I'd now like to introduce today's witnesses. This afternoon, we will hear from Dr. Cameron Matthews, Deputy Undersecretary for Health for Community Care, and Dr. Jennifer McDonald, Chief Consultant at the Veterans Health Administration. Next, we will hear from VA's 2 community care contractors, and with us today are Mr. Dave McIntyre, President and CEO of Tri-West Healthcare Alliance, and Lieutenant General Patricia Hiroho, CEO of OptumServe. Finally, we are joined by 2 witnesses that will offer their perspectives and share community providers' experiences delivering care through VA's community care networks. Mr. William A. Dombey is the president of the National Association for Home Care and Hospice. Thank you for joining us. And Eric Golnick and Eric Freeman are co-founders of the Veteran and First Responder Healthcare, which offers substance abuse and mental health treatment in several cities, including my hometown of Manchester, New Hampshire. Thank you for being with us. We will begin by recognizing Dr. Matthews for 5 minutes.
Good afternoon. Good afternoon, Chairwoman Brownlee, Chairman Pappas, Ranking Members Bergman and Dunn, and members of the subcommittees. I appreciate the opportunity to discuss VA's continuing success in implementing the new community care program via the VA Mission Act of 2018. I'm accompanied today by Dr. Jennifer McDonald. This is a time of transformative change at VA. Mission Act implementation is succeeding and has become part of our core business as we prepare to deploy additional benefits to support veterans and their families. On June 6 of 2019, we successfully launched the new Veterans Community Care Program, a cornerstone of the Mission Act, and have authorized more than 3.85 million episodes of care in the community. Veterans now have enhanced care options, and we are streamlining our processes and technology to make their experience of care even better. Timeliness of claims payment to community providers remains a top priority. I acknowledge that the growth of community care, including unauthorized emergency care and antiquated payment systems with many limitations, have led to a growing claims payment backlog. We receive more than 1 million claims a month, and while we can process that incoming volume, we need further transformation to attack the backlog that is now more than 2 million aged claims. This is a backlog that has accumulated since before the Choice program, and I have been working tirelessly since taking this role to eliminate it. Our goal is to work down the claims inventory by the end of this fiscal year. A new claims system was implemented late last year, which provides automation of authorized claims. Additional automation will be introduced this spring. We have developed business rules that streamline the manual processing of unauthorized emergency care claims, which comprise the largest portion of our backlog. Additional contract support, along with my staff, now use these rules. In addition, as more care moves to our community care network, VA's third-party administrators are able to pay claims on VA's behalf and are doing so in a timely manner. We are committed to being an excellent partner to the community providers in our network. We have to get this right. However, when we do not get it right, we need to be transparent and fix the issue as soon as possible. In the beginning of this fiscal year, VA implemented a new standardized rate structure for home health. This new rate structure ensured a more accurate and standardized reimbursement rate methodology that accounts for variations in services and locality costs. However, after feedback, we agreed that in some locations, the change needed to be more gradual over the course of several fiscal years. We worked to mitigate the issues, and we have loaded the new fee schedule in VA systems last week. As we continue to transition to these new networks under the CCN contracts, which I expect to be deployed across the first 4 regions this fiscal year, we need to ensure that veterans have a seamless experience and that we maximize opportunities for continuity of care. As a primary care physician, I hold this as the ultimate priority, and therefore we are stepping away from industry standard in order to ensure a veteran-centric approach to this transition. Effective change management is therefore critical. Veterans in Regions 1, 2, and 3 who are in the middle of an authorized episode of care under the Tri-West network will continue that care until the episode of care ends. With other payers, that care would instead abruptly end. For veterans, if additional care is needed, it will transition under the Optum network after, not during the originally referred episode of care. This allows the veteran to continue her or his care with the providers with whom they have established a relationship. We know we have began implementing the Mission Act that we had the potential to make an enormous positive impact for America's veterans. Today, we have begun to demonstrate that potential. I am very proud of the future that we are building on behalf of veterans and their families, and sincerely appreciate these committees' continued support. This concludes my statement. My colleague and I are prepared to answer any questions you may have.
Thank you, Dr. Matthews. I'll now recognize Mr. McIntyre for 5 minutes.
Good afternoon, Chairman Pappas, Chairwoman Brownlee, Ranking Members Dunn and Bergman, and members of the committee. Thanks for the opportunity to appear before you today on Lincoln's birthday to discuss issues related to VA community care. It's an honor for all of those of us associated with Tri-West, from our nonprofit health plan owners to university hospital systems to nearly 3,500 employees, most of whom are either veterans or veteran family members, and our subcontractors, to be supporting Drs. Matthews, McDonald, and the entire solid team at VA as they seek to deliver on Lincoln's words uttered at his second inaugural address, to care for whom shall have borne the battle, and his widow and his orphan. Those words equally applied to both males and females, and the commitment of a grateful nation to be resolved to meet the needs of those who have defended our freedoms are as poignant today as they were when uttered in 1865. For the past 6 years, we have been called on to construct a community care network VA could rely on for the care that they needed to place in the community, to process and pay claims, and to deliver customer service support to veterans, providers, and VA staff. On December 7th, 2018, to honor World War II veterans, we stepped up to take over the rest of the country for a while at the behest of VA, as they had to let another organization go that was responsible for doing this work. We will forever be grateful to the nearly 700,000 community providers across the country who answered our call, and for whom we have now processed and paid more than 23 million claims for health care needed by veterans to an accuracy rate of in excess of 96%. Just 11 million of those have occurred just since the start of the Mission Act, and we look forward to getting to our personal goal, which is in the 99% range in the near future. With the exception of a challenge at the end of last year, which jammed up nearly 400,000 claims, for which we are nearly finished with the processing and payment, and 10,000 ER claims that we and VA are working through, we have been processing and paying claims within the 10 days that we committed to do in the former HealthNet area, and for an average of 16 days nationwide, as we said we would do. The care in which we've been engaged includes everything from making sure that the next veteran generation gets delivered, to eye care, to cancer care, to health care services unique to female veterans, to primary care and mental health, and to transplants and everything in between. Due to those providers who answered the call, we return less than 2% of care requests for no network provider available. Mr. Chairman, you talked about Dartmouth. We had the opportunity to visit on that yesterday. Out of the 4,137 bills that they provided us, there are only 458 pending, of which only 130 are 30 days old, and the oldest is in October. Since June 6th, this privileged work now includes a new urgent care benefit. As of today, there have been over 190,000 encounters, with more than 90% of this nation's veterans having access to such care within 30 minutes of their home. We're humbled to have been selected to continue this privileged work in our native territory of the West under the CCN contract for Region 4. And we welcome Optum to this critical work, and we will continue to fulfill our commitment to have overlap in their markets as they stand up strongly at the side of VA to deliver. With regard to the coming CCN contract in Region 4, we and VA are engaged in a full team sport, just as we've been doing for the last 6 years, To ready ourselves for the next leg of the journey in this transformation, we're implementing new tools and processes, assessing what we will believe will be the demand for care and services, and charting the implementation journey which we expect will deliver for veterans and for VA and for community providers who we call on to support. And that rollout begins with Montana and eastern Colorado on April 7th, and will conclude in mid-July with the rest of the region. There's a lot going on. As some of you have indicated today, it's a challenge. There's a long roadmap, and it's extensive, embodied in the Mission Act. It is a privilege to do this work, and we are confident in our ability to deliver. I'd like to close, though, with a story from a veteran who we're all responsible for serving that got conveyed to us last week. "I was in really bad shape physically and mentally," said Thomas. "I'm pleased to say that I've now gone 12 days without a seizure. I learned a lot. The doctors here have done more to help me with my physical problems than I've received in 20 years. I did not know there was a treatment for alcohol detox. Since being here, I recognize that I've been in denial about my alcoholism for 48 years. I was in a wheelchair when I came here 30 days ago. Yesterday, I was shooting hoops, and now I have hope." That's the promise of what you all have birthed, and we are privileged to do at the side of VA. We look forward to doing our part. We look forward to applying the lessons we've learned, and I look forward to responding to any questions that you might have. Thank you very much.
Thank you, Mr. McIntyre. I'll now recognize Lieutenant General Hiroho for 5 minutes.
Chairman Pappas and Chairwoman Brownlee, Ranking Members Bergman and Dr. Dunn, and members of the subcommittees, I'm Patty Horoho, CEO of OptumServe. On behalf of the more than 325,000 men and women of the United Health Group, we are honored to be part of this mission, to provide community care networks for Regions 1, 2, and 3. The veteran is at the center of everything we do. We have a long history of serving our nation's military and veterans. Our mission is to deliver a high-quality provider network to meet the needs of our veterans, and we are dedicated to fulfilling that mission. I am pleased to report Optum is on track in fulfilling that mission. Thousands of veterans are utilizing our high-quality, broad community care network. Providers are getting paid promptly. We are providing timely and responsive customer service, and we're continuously building and adapting our network and operations based on data and utilization trends. Central to our responsibility is delivering a network of high-quality health providers from which VA staff and veterans can choose. To build this network, we began by leveraging the 1.3 million providers and 6,500 healthcare facilities in United Health Network and Optum provider networks. But that was just the beginning. With the VA, we are identifying and adding preferred providers who have a history for caring for our veterans. Today, in Region 1, our network includes more than 178,000 unique providers and health systems across more than 309,000 care sites. And taking a data-driven approach, we continue to evolve the networks across all 3 regions to meet the needs of our veterans. On December 10th, we completed Region 1. Since then, taking a data-driven approach, we have expanded the network by more than 25%, adding 35,000 unique care providers over 62,000 care sites. Central to the success of the program is the provider experience. This includes paying them promptly, which underscores that Optum is a reliable partner, thus increasing provider confidence in continuing to deliver for our nation's heroes. As of today, we have processed more than 150,000 claims, and we paid these claims in an average of 11.9 days. Another critical element is answering questions and resolving issues as they emerge. As of today, we've received 35,000 calls to our customer service center from VA staff and providers, with an average speed to answer of 3.6 seconds. And most importantly, we resolve more than 99% of the questions or issues on the first call. We also want to ensure providers have the information they need to participate in the community care network. Our communications approach uses different channels, including proactive letters, calls, and in-person meetings. After providers join our network, we utilize webinars, in-person trainings, and virtual town halls to train them on the new network. We provide regular updates, education materials, on-demand videos, and the ability to upload and track their claims all online. And we are restless in our desire to do more. We are committed to identifying new and effective methods in which to communicate with providers. In conclusion, 7 months into healthcare delivery, veterans are getting care from our network. Providers are getting paid promptly, and we continue to adapt and build our networks across all 3 regions in strong partnership with the VA and Tri-West. We are equally committed to continue our open lines of communications and regular engagements with Congress, the veteran community, and our stakeholders. We share your commitment to ensuring this program delivers the experience our veterans deserve. 50% of our community care program staff are veterans, and I'm a veteran. We understand why getting this right is so important. Members of the committee, thank you for what you do every day to support our veterans, and thank you for this opportunity to testify.
Thank you for your testimony. Mr. Dombey, you're recognized for 5 minutes.
Thank you for the opportunity to submit testimony here today. The Veterans Administration's healthcare benefits for home-based care present one of the most robust arrays of supports for care in the home. This shows a strong commitment in the VA to provide significant and unrivaled home-based care opportunities. There can be no doubt that the VA is a leader in providing cost-effective, high-quality, and innovative home care services. While designing a package of home care benefits for veterans is an important step to meeting their health care needs, it is equally important that the benefits be implemented in a timely and effective manner. The transition to the new community care program demonstrates that proper implementation planning and execution can make a dramatic difference in delivering on the promise of home care services. At present, there is room for improvement. However, there's also time to learn from the lessons from the early stages of the transition to establish implementation improvements. In that respect, I'll focus on the experiences in home care programs to date. There, the issues that have surfaced involved 1, confusing communications, 2, securing an adequate supply of care providers, 3, care authorizations, 4, payment delays, and 5, payment rate cuts. Each of these subjects are addressed in more detail in my written testimony, but I'll touch on them briefly. Communications is a big issue always in healthcare administration. Our members of the association report ongoing difficulties in gaining an understanding of what is changing through community care, who's responsible for the various parts of the transition, and how the care authorization process and provider enrollment process is supposed to work. Today, it is near impossible to find the detailed information needed to determine what is required for an existing VA home care provider to qualify to provide services in community care. For veterans, determining how to access home care benefits is also a major challenge. We recommend that the VA initiate website revisions that provide for improved navigation and content that answer these and other basic questions. Due to changes connected to the transition to community care, many of the long-standing home care providers are now on the outside looking in, turning away prospective patients on a daily basis while waiting for months to complete a credentialing, contracting, and enrollment process long after the transition has started. Today, many months after the start of the transition, significant numbers of previously qualified home care providers are still waiting to requalify. One company alone reports over 250 locations on hold. We recommend that the VA consider revising the provider enrollment process to avoid a loss of access to care, improve the options available to veterans, and ensure that patient needs are prioritized over paperwork. The revisions could follow a path traveled by a number of state Medicaid programs. There, the transitions permitted beneficiaries to continue receiving authorized services from their existing provider for 6 months or more. There was a grandfathering of existing home care providers while undertaking any desired credentialing and contracting, and maintaining existing payment rates for some designated period of time. It was heartening to hear that some of that is already now in process. This manner of programmatic transition secures near seamless experiences for patients and providers alike without creating any significant difficulties for the benefit program. With respect to care authorizations, it has been a long-standing problem with VA home care. Care authorizations continue in community care problems. Home care providers report ongoing difficulties in getting authorizations processed timely, sometimes waiting 6 months or more to start care. As a result, some home care providers report that they've stopped admission of any new VA patients. In the absence of care authorization, care cannot start, putting the veteran at risk. We respectfully recommend that the VA take immediate steps to expedite home care authorizations. One approach is to rely upon the judgment of the professionals actually providing the care for that veteran and cover care when certified necessary by that attending practitioner. Payment delays do continue to abound. Our members report delays of multiple months. It has reached a level of concern that a number of providers are discontinuing admissions of VA patients. No business can carry receivables for an extended period of time, and home care companies operate on human capital with payroll due every week. We recommend that the VA establish a clean claim payment deadline. Failure to meet the deadline should require the payment of interest on the amount owing. And rate cuts, the chairman mentioned that in his opening statement. When payment finally arrives, it's not always a pleasant surprise. Home care providers report unilateral rate cuts to levels far below the cost of care with no explanation. In many instances, the rate cuts are retroactively applied. Cuts of this nature trigger lost access to care. Rate setting appears to occur behind the curtain, leaving patients and providers often in the dark. We recommend that the VA maintain a transparent rate setting process that's focused on real-life care costs and a level of payment needed to ensure uninterrupted access to care. Again, it was heartening to hear from the VA that they've got something of that nature in process. So in conclusion, we greatly appreciate the opportunity to provide the committee with the foregoing information. We stand ready to partner with the VA and its contractors to develop all necessary steps to ensure a viable home care program fully accessible to our nation's veterans. Thank you.
Thank you for your testimony. I'll now recognize Mr. Golnick for 5 minutes.
Good afternoon, Chair Pappas, Brownlee, Ranking Members Bergman and Dunn, and members of the subcommittees. Thank you for inviting veteran and first responder healthcare to testify today regarding our experience as a community provider working with the VA and with third-party administrators. As a former naval officer who suffered from post-traumatic stress and substance use issues, I'm acutely aware of the importance of advancing and improving veterans' access to health and the hard work that these committees do, we sincerely appreciate. VFR Healthcare, along with our sister organization, Strive Health, is a veteran-owned and operated organization that was founded to increase the access to and quality of outpatient substance abuse and mental health treatment for veterans, first responders, and their families. In June 2018, we entered into a partnership with the VA to enhance veterans' mental health and treatment to reduce suicide. Since then, we've been working together to advance and improve veterans' mental health and well-being. Through this partnership, we were able to successfully enhance veterans' access to behavioral health care. For example, 100% of veterans referred to our programs have a scheduled intake within 24 hours. We're honored to be partnered with the VA and have had the privilege of working and providing behavioral health treatment services to veterans over the last few years. In doing so, we've had the unique experience of working with VA and providing health care services to veterans through several different community care programs and transitions. As a veteran-run company, we are mission-focused on ensuring that veterans and their families get the highest quality care they need in a timely and efficient manner. As such, we assume the administrative burden on behalf of the veterans to make sure that any issues with billing or authorizations are taken by us. Taking on the administrative burden for veterans is especially important in mental health and substance use treatment, as these administrative issues can cause stress and anxiety for veterans at a time when stability and structure in their lives can be life and death. Now, before discussing our experience and challenges we've had as a provider, I think it's important to mention that we are also in network with over 15 separate commercial health insurance companies and 2 state Medicaid plans. The challenges we've experienced with the TPAs are not unique and happen quite often with other health plans during periods of transition. It's our hope by illuminating these issues and providing some insight as a community provider, we can assist in making the community care network more efficient and the transition to other regions easier. So I'll now go through some challenges we've experienced. First is a clear delineation of roles, responsibilities, and troubleshooting process. On multiple occasions and spanning several different categories, we've run into administrative issues that both the TPAs and the VA were unable to resolve. In these instances, we followed protocol, spoke with TPA employees who informed us that the local VA was responsible for addressing these issues. We then spoke to the local VA, who then told us that it was the TPAs responsible for resolving these issues. In all these cases, we ensure that the veteran is still being taken care of. We're not going to let that burden affect them. Second issue we run into is the ensuring a seamless referral process. We've spent a considerable amount of time with our VA partners and the TPAs to understand the referral processes and potential pressure points. While the new CCN allows VA staff to refer veterans to community providers, in practice, there are several what we would call pressure points where the referral can either be slowed down or almost stuck. Third is an efficient and accurate uploading into the TPA system. A complete and accurate upload of a community provider to a payer system is critical to ensuring that proper referrals are generated, claims and payments are appropriately paid, and accurate information is provided to veterans and referring providers. Any issues with this upload present dire consequences to the community provider and significantly affects the care currently being provided as well as the care coordination with the VA. Fourth, uniform claim submission and reconsideration policies. Claim forms, which healthcare providers submit to get paid for services rendered, are extraordinarily complex and comprehensive. As such, setting and adhering to uniform claim submission and reconsideration policies is paramount to the claims and payments that we are able to resubmit and properly adjudicate them. In conclusion, we appreciate the opportunity to address the subcommittee today to assist the VA and TPAs in their collective mission to enhance the health and well-being of our nation's veterans. We believe the Community Care Network is critically important to ensuring veterans can access necessary care in a timely manner. It is imperative that processes, systems, and control are in place so VA, the TPAs, and community providers can work seamlessly together to enhance access to care for veterans. While community providers like us are bearing the brunt in the short term, they are not unique to the VA or the TPAs, and we believe they are solvable challenges. We are confident that the VA and TPAs will work diligently to resolve these issues. We believe the VA and the TPAs and community providers will work together efficiently as a team to ensure that veterans receive timely and adequate care. Chairs Pappas and Brownlee, Ranking Members Bergman and Dunn, and members of the subcommittees, this concludes my statement. We'd be happy to answer any questions any other members of the committee may have.
Thank you very much for your comments and to all the testimony that we heard from our panel. We'll now turn it over to questioning, and I'd like to begin by recognizing myself for 5 minutes of questioning. We just heard from a witness, a community provider, who talked about frustrations that they have seen with the system, bureaucratic issues that result in this kind of palpable frustration that I hear from so many providers in my district. And some of it comes down to a lot of this, which is that a provider is told to go to VA, and VA tells the provider to go to the third-party administrator, and it's this circular loop that sometimes they can't get out of. So I'm wondering if I could hear a little bit from Dr. Matthews about the support that you offer to providers and how we can get all the parties together to help address some of these concerns and allow people to just get the bill paid and provide the care to veterans that they want to provide.
Sir, thank you so much for that question. I am in complete agreement, not only with our colleague on the panel, but with the intent behind your question. We do need to streamline this process. I like the language that was used, not only about claims, but also referrals and authorizations. There needs to be uniform processes on how to do this. What we have adopted and actually have rolled out to all VA facilities is a purchased referral and authorization system so that there can be communication with our partners in the community, that there can be even messaging, but also sharing of referral and authorization data, of even sharing medical records, so that there is a streamlined approach to how communications occur more than anything. A lot of times there's difficulties in finding the right partner. There's the finger pointing, as you notated as well too. We really are streamlining how those communications occur by just increasing the technology that's available. It's not a phone call, which is just an outdated format. I think the other piece that I think we are still recovering from through the Choice program was the need for the TPAs under Choice to authorize the care. So there was often some decision-making on the part of the TPA, which was wholly unsatisfactory for the veterans, for VA, I think even for the TPA speaking on their behalf. Under these new contracts, the authorization, the referral information, the scheduling, everything that is veteran-focused remains with the local VA. The facility is the one scheduling, the facility is the one authorizing that care, making those decisions. Our third-party administrator partners are there to build the network and to pay the claims. That is more industry standard, and we hope that our partners in the community have a appreciation for that simplification. But we do need to have more consistency, admittedly, amongst our facilities on how they use the new HSRM system and how they communicate with their providers, and we are providing that sort of training and capability so that it can be streamlined in every way possible.
So how can we measure that over time? I mean, one of the concerns is, you have cited some process improvements that I think could help this situation. But if we're not getting feedback from folks like Mr. Golnick, how do we know how we're doing? So I guess, how do you stay plugged into the provider community?
Yeah.
How do you measure satisfaction? And do you have a tool that you could use for that?
It's a great question, and when I was going to answer exactly the wording you used, we would like to have a greater sense of provider satisfaction. We have multiple surveys within the VA of veteran satisfaction, but actually through our third-party administrators, the network is responsible for collecting provider satisfaction data, so therefore we can actually take action and improve when these sort of shortcomings are still in place. So I look forward to that data. We haven't had it in such a comprehensive way previously, and again, one of the benefits of having strong partners here to help us implement that is that it can be uniform across the network, and then we're best suited to then act on it.
In the referral and authorization system that you mentioned,
Yes.
is this new? When was that implemented? Because I'm hearing so much back home about claims not being processed in a timely fashion. Is there some kind of a breakdown in this particular system, or is it?
No, so multiple systems have actually been rolled out over the fall. The referral system is purely the one where the VA provider enters a referral and authorization, and it actually can communicate directly with the community provider if they so choose to use it. It's a cloud-based format, and they can sign in and read about the referral. That was fully deployed over the fall. Not every facility has been using it because it's actually meant to interact with the community care network as opposed to other providers that we have contracts or relationships with. So as the facilities have been deploying to CCN, meaning launching to either Optum and soon to be the newer network under TriWest, they will be using HSRM more.
Sure. Do you know how many providers are using it? And then my time is up.
Unfortunately, I don't, but I can get you that information.
But I think that would be helpful to know. Thank you for your responses. I'll now recognize Dr. Dunn for 5 minutes.
Thank you very much, Mr. Chairman. I want to say make a couple comments first. Dr. Secretary Matthews, I was thoroughly impressed with the progress you've made. You hit the community care programs in such a short amount of time. I enjoyed our discussion earlier this week. We both know there are still areas that can be improved, but I'm grateful for and reassured by your very obvious detailed grasp of those problems and your proposed solutions, and frankly, your professionalism as well. General Horoho and Mr. McIntyre, speaking as a community doctor who has cared for veterans in community care programs for decades, and I'm a veteran, let me say that the early results of your implementation of your portion of the Mission Act has been a breath of fresh air. I've spoken with a sampling of my doctors and my hospitals back home about their experiences specifically since D-Day 2019, and each of them noted dramatic improvements. I also spoke this morning with the chairman of Duke University Department of Surgery, who happens to be a transplant surgeon. And prior to the Mission Act, his veterans could not receive an organ transplant anywhere in North Carolina. They were forced to travel to Memphis, Minneapolis, or Pittsburgh repeatedly for these services. He happily reported this morning that these veterans are now being allowed to receive the care right there at home in North Carolina, in his case at Duke, and further that the relationship between Duke and the VA hospital, which is directly across the street, is better than ever. So first, Dr. Matthews, I'd like you to briefly share with the rest of the subcommittees here your plans to address those. Well, I think you actually did just now, actually, with Chairman Pappas, the addressing the authorizations. I think that's great. There are also some problems, however, in the urgent care area, hospice. There are little hiccups there, home nursing. Briefly, just kind of reassure everybody else as you did me earlier this week.
Excellent question. Thank you so much, Dr. Dunn. What we've instituted, honestly, towards the end of the choice program, but are more comprehensive with the approach now, is a concept of a bundled authorization, not a bundled payment the same way CMS pays for things in bundles, sorry for being repetitive, but that in referring for the care and placing the order for the care, the VA provider is acknowledging a package of care that could be associated with that. So if you're referring for a hip surgery, we're authorizing the physical therapy that goes along with it. We're authorizing the follow-up visits, the prescriptions associated with the labs, the x-rays.
That was so key. I
It's-
can't tell you
it's
how many
critical.
times somebody authorized to see me but not have a CT scan. I mean,
Yes, this is just commonplace in really the managed care space. And in VA, we now have these are called standardized episodes of care, or CEOCs we also call these. This is critical, and they are being fine-tuned for exactly the services you mentioned, Dr. Dunn.
And I know they are.
Home health.
I
and-
wanted the other members of the committee to hear that because we took a deeper dive in it individually. General Rojo, Mr. McIntyre, your great experience with you. I will say the credentialing still could use a little massaging there, but I think you're up to it. It looks like the easiest one of the problems that we still had remaining. I guess what I'll do is I'll close and I'll say I want to continue our collaboration. I want to continue this conversation and communication back and forth with the committee. We want to give each other feedback, and I'll get my feedback from my veterans and my my hospitals and doctors back home. But we need to have all of us talking to each other about these kind of problems, and I think after we have a year's worth of data under our belt, perhaps sometime this fall we could do this again, maybe September. If you would have the data ready by then, if you can. I'll bet I'll humbly beseech Chairman Pappas and Chairwoman Brownlee, and General Bergman, all to join me again up here and hear how things are going 1 year in. But so far, I'm cautiously optimistic, and thank you very much for your efforts on behalf of our veterans. I yield back.
Thank you. I think that would be timely, given the VA's indication that these 2 million age claims will be dealt with by the end of the fiscal year. We can see how things are going there. So I'll recognize Chairwoman Brownlee for 5 minutes.
Thank you, Mr. Chairman. Hello, Dr. Matthews. It's good to see you again after our travels to the Dakotas. It sounded to me in your testimony that you understand now about these rate reductions around home care issues. It was very alarming when I heard Mr. Dombey, is that correct? Mr. Dombey's testimony of these rate reductions, and then, charging these providers retroactively a lower rate. So it sounds to me as though you recognize that, and maybe you could talk a little bit about how you're going to address it.
Sure, excellent question, and really, I admit that this was a fumble on our part. The fee schedule is actually updated on an annual basis at the beginning of the fiscal year, but as our colleague Mr. McIntyre acknowledged, the fee schedule got out late. This will be corrected moving forward. However, then in the fee schedule, there were several errors. Those have since been corrected. The new fee schedule has been updated into our claims processing systems, and we will be processing all the applicable claims back to the beginning of the fiscal year at the improved and updated fee schedule, and there's no additional work that the community providers need to do, no resubmitting of claims.
Okay, when you say the rates, there were errors, do
Yes.
you, I want to hear from you specifically that they were reduced improperly.
I actually can't confirm that, ma'am. This was a fee schedule that was created through several subject matter experts who were communicating with the field, as well as, I believe, with some community providers. That's how they created the fee schedule. I can't necessarily confirm that they were in error, with the exception that they were most likely reduced a little too quickly from prior rates. And so they've been adjusted back to something more reasonable and accepting for our partners.
Well, that still remains a concern for me then, because you know, honestly, and in the hearings that I've had with in my subcommittee, you know, this silver tsunami that's moving through the VA, you know, a large cohort of veterans who are 70 years or older, who are going to need, you know, in-home care. This is where veterans want to be, is in their homes. They don't want to be in a nursing home. They don't want to be institutionalized. And quite frankly, by serving them in home, it's win-win, because it's where they want to be, and it's actually cheaper in terms of our resources. So I want to make sure that you know, the right incentive is there to provide in-home services, you know, throughout the country. And if we're going to begin to reduce rates when the cost of care is increasing, it sounds to me that's going to diminish our supply, and that's a concern. That is a concern for me. So I hope when you're looking at the rates, you know, that you're taking a hard look at regional costs, and keeping those rates at a level where we can increase the supply, because the demand is going to be greater than the supply, and I think we have to move in that direction.
Can I clarify one point on that fee
Sure.
schedule? These are only rates that we're adjusting that do not have applicable Medicare rates. Any other in-home services that have Medicare rates, we follow the CMS fee schedule. This
Right.
is only when we need to
Right.
create additional fees that CMS does not
Yeah.
cover.
So, Mr. Dombey, based on what you just heard, can you tell me what you feel the impacts are?
I mean, the impacts to date have been on essentially just access to care. I'm wondering, after hearing what I'm hearing, you know, is this a deja vu for being the second child in the family? You know, perhaps it's home care services that was last out of the gate in terms of actions taken, because it seems that we have been bearing the brunt of some of the administrative actions and some of these little snafus that have occurred there. So when I say second child, no, I don't need any psychological counseling. You know, I've weathered that storm, and now identify with my grandchildren who are the second child in their family. But, you know, home care has been a stepchild, but, you know, we can announce here today, we're going to take over the healthcare world, and so we'll get the respect eventually.
Well, I hope the two of you will converse and talk and work this out. I have a very little time left. So one question, Mr. McIntyre, that I wanted to ask you. And you're in my office yesterday, you said mental health usage in the community has increased 400%. Which was astonishing to me, quite frankly. My question, and very quickly, because I've run out of time, is, are those veterans who are receiving community care for their mental health needs, are they also getting the wraparound services that they would normally be aware of and accustomed to by receiving their mental health care within the VA? And I think I've used my time, so maybe you can get back to me on
You
the
want it
answer.
for the record?
For the record, I yield back.
All right. The one thing that I would say, if I might, is that you all adjusted the access standards for mental health, among a few other things in the Mission Act. That's what drove the increase in demand going into the community, because it said to everybody involved in this process, folks need to be seen faster. And so there's a limit in supply sometimes, and that's why the elasticity of the community exists in these contracts. And that's where the increase in demand came from.
Thank you for your comments. I'll now recognize Ranking Member Bergman for 5 minutes.
Thank you very much. You know, as we have the different entities here, it's in some ways it's no different up on the dais here than it is for you at the testimony table. We're only going to be successful if we build relationships at all different levels across any potential boundaries. And Mr. Golnick, I'd like to just thank you for not leaving anybody behind and being a first responder. you're setting the standard. Others can emulate that. Dr. Matthews, what are you doing to build relationships with providers?
Great question. We have built over the past couple of years, actually, a provider engagement team within community care within our office. I admit that it hasn't necessarily been an audience that has a dedicated area for communication and information prior years where websites weren't updated, but really it's one of our priorities. Without our provider partners, we obviously couldn't provide these services to veterans, so we are really looking to improve communications. We have more direct consultations available for providers to communicate directly with my staff. We have monthly webinars and trainings where they can not only learn about our business operations, but also take a lot of the training that VA providers have. We emphasize suicide prevention and a lot of the other veteran specific conditions, even the ones acknowledged under the Mission Act. We are really doing as much as possible to hit a broad audience through available resources. In addition, myself and other leaders in my office, we are definitely communicating with different member associations. I'm presenting to multiple different hospital associations, primary care associations, AAMC. We attend many conferences just to get out the language, the messaging around really VA's acknowledgement.
And I hate to cut you short because it's a long answer, and you're obviously doing a lot of things. Remember, communication is not what's said; it's what's heard. So as you're communicating, I don't want to sound instructional here, but if you can receive feedback at the same time you're trying to communicate to see if your message is being heard in the way you intend, and also kind of to piggyback a little bit on the fee schedule piece, Dr. Matthews. This is the type of situation that should be avoidable and negatively impacts the VA reputation, because not only are the veterans concerned, but the providers, as we saw prior to, when you don't get paid and you don't know what's going on, that kind of destroys their confidence. And for Dr. Matthews and General Hiroho, I'd like you to take this one for the record, because it's a long answer, but my office has received complaints that for some veterans, it is still taking months to process approvals for community care. With Optum going live in Iron Mountain in my district next week, I'm asking your help to manage expectations there. How long should a veteran expect to take from the point of referral by VA to a community provider to the point of seeing the doctor in the community? I mean, should they expect that right away, or will it take time to get there, or if it'll take time, how long? I mean, do you have any metrics or goals that maybe you see here you are today and where you're trying to achieve reasonable goals?
Sir, we will take this for the record as you asked, but happy to communicate directly with you on this and engage your office if you'd like. We have briefed staff on our new referral coordination initiative, which will take care of this. Urgent referrals, VA processes in 2 days and gets that care delivered. So it's the routine referrals that you're addressing, and we'd be happy to go deeper on that with you.
Yeah, it is, because it's about setting expectations, and it's, just getting those, getting the answers. Mr. McIntyre, I know I got about a minute left, but would you please elaborate on Tri-West's demand capacity assessment process and how it informs Tri-West's efforts to build its provider network?
Yes, sir. Thank you for the question. We used this set of tools most recently to lay down the urgent care network for all of your districts across the country. And basically what we do is we understand and chart out where veterans live, so the actual address of their rooftop. We look at the demand profile from each one of the VA medical centers wrapped around that population, and then from that we figure out what the supply needs to look like for each of the specialties for which someone needs to see. We've been using this set of tools since after 9/11, when we built networks for the Guard in states like Idaho. We picked it up in the crisis in Phoenix. Then we used it for urgent care, and we've just finished the assessments with VA at the ground level in Region 4, and that's informing how we will set the network for Region 4 going forward.
Okay, thank you. Mr. Chairman, I yield back.
Thank you, Ranking Member Bergman. I'd like to recognize Mr. Lamb for 5 minutes.
Thank you, Mr. Chairman. Thank you to all of you for being here. Especially thank you, Mr. Golnick, for coming all the way from New Hampshire. Good to see you again. veterans example that you gave in your testimony, it still hadn't been cleared up after almost a year of non-payment. Was that an old Tri-West claim, or was that an Optum claim the entire time? I'm sorry if I didn't pick that up.
That was a Tri-West claim.
Okay. So we're hoping that with Tri-West resolving those old claims in the next year, that would be resolved along with the rest of them. Is that your expectation now?
I am not sure what our expectation is, to be frank. I'm hopeful that we'll get to a resolution because in this example, we have the referral in hand that has been authorized, but no one knows from the TPA side or the VA side what to do next in order for the claims to be reimbursed properly.
Okay. And I know from talking to you, Mr. Golnick, that you operate in Pennsylvania as well as New Hampshire.
That's correct, sir, yes.
Have you seen similar issues with the TPAs in getting paid on time in Pennsylvania, or is there a geographic difference, or is it the same?
Go ahead, please.
Yeah, we've actually seen in Pennsylvania, it's been a better, more efficient process, and maybe that's, again, learning from lessons that started out in New Hampshire. But really, unfortunately, in New Hampshire is where we've experienced most of our issues.
Okay. And then as far as the provision of care itself, Ms. Chairwoman Brownlee was asking a little bit about this, the increase in mental health provision in the community. Would you say that there's anything different about the way that you provide mental health or substance abuse treatment to your veteran patients than what they would get in the VA? I mean, I know obviously the setting is different, but as far as the actual care and the evidence it's based on and the style.
It's all the same evidence-based treatment, and we actually partner quite well with the VA, with the local VAs. Our main focus is intensive outpatient treatment, which is the 3 hours, 3 days per week of substance use treatment, and we also do outpatient, but it depends on what the need of the local VA is. So if they need us to do more outpatient treatment, we will do that as well.
So I thought that's what you were going to say, and that makes me even more confused as to why it's difficult to reimburse on time, because it's not like you're providing something that the VA wouldn't recognize. It sounds to me like the actual services, interventions, therapies, whatever you want to call them, toward your patients look similar to how they would be inside a VA hospital. Is that fair to say?
Yes, absolutely.
So what do you think the friction point is as far as making sure that the bundle of services you provide once you get the authorization, what really is the friction point with the payer? Do they not understand what you're doing, or?
So unfortunately, behavioral health is a not really understood side of the healthcare industry. And so, for example, we are licensed as a facility, but some insurance companies accidentally consider us a provider group, which we're not. We're a facility. So there are two claim forms. We could submit via a facility claim form or a professional claim form. And so often, if a policy is not set to begin with, we'll get denied for using either or both. And so really what it comes down to is, unfortunately, in behavioral health, it's just progressing and becoming a healthcare industry that insurance companies are paying attention to.
And I do want to emphasize that on the ground level, the actual clinicians that are setting the referrals up, they understand what we do, and we work very well together. I think once it gets past that level is where we start seeing the issues.
I see. Okay. The last thing I wanted to ask was, do you have patients that take advantage of some of the types of services that VA is now offering under the whole health spectrum? So acupuncture, massage, nutrition, meditation, all that kind of stuff?
Absolutely. I think one of our main focus is to make sure that when the veteran comes to us for treatment, they understand and are aware of all those treatments options. And again, that goes back to the partnership with the VA. We're trying to make sure that these vets, a lot of them are hesitant to come to the VA, that they understand that there are all sorts of services that they're eligible for.
Do you tend to see veterans use some services at the VA and your services, or is it more of a clean break from the VA institution once they come to you?
No, they back and forth. We
Yeah.
mostly see back and forth.
Okay.
Absolutely.
I really want to thank you two for what you're doing. I know you do excellent work in my home state as well as New Hampshire. And please keep it up. We'll do everything we can to make it easier on you. Appreciate it.
so much.
Thank you, sir.
Mr. Chairman, I yield back.
Thank you very much. We're very lucky to have the ranking member of our full committee, Dr. Rowe, here with us, and I'll recognize him for 5 minutes.
Thank you, Mr. Chairman. If I had a problem getting paid with Tri-West, the solution's right down the end of the table right there. I'd be speaking to him before I leave. And secondly, we have a guest in the room, I just noticed sitting on the back row, who did tremendous work on the choice program. I remember many nights I spent with Chairman Miller, Jeff Miller, who's in the back, who really teed all of the Mission Act up with his work as chairman. And Jeff, I want to thank you for all the work you've done for veterans, and we wouldn't really, I think, be having this hearing this afternoon had you not done the great work you did on the committee. I think Julia was here and Mr. Sablon, so thank you for that. Just a couple of questions, and we have two generals here. I'm going to salute the Army general. And a question to you and Mr. McIntyre is, how long on average does it take for a new provider to become credentialed once and begin seeing patients as a part of the network? And both of you can answer the question.
Thank you so much, and also thank you for your service as well. When we look at those to build the network first, I'll kind of bring it in. And so one of the things that we started out doing is we looked at the civilian population, 2% of it, to build a very large network. And then now we brought it down to using referrals, so we're very data-driven. So once we identify providers that need to be in the network, we ensure that they're high-quality providers by credentialing them. The average time for credentialing is around 15 days. It can be a little bit longer because it's very dependent on providers submitting the information, so we could do prime source verification, check their education, check the National Practitioner Data Bank, and then once that is done, then they're loaded into our system, and then they're available for the VA to be able to see, to make a referral.
We have a consistent process. It's overseen by URAC. We draw from the nonprofit Blue Cross Blue Shield backbone for much of the network that we have access to. If you do a full credentialing process for a hospital, sometimes that can take a long time, and all the associated practices that are tied with that, but most of the professional stuff fits into the same category of what General Horoho was talking about.
Well, one of the things that the whole idea of the Mission Act was to say, okay, the VA can't provide everything. The community can't provide everything for everybody, so we want to have a shared goal here of taking the best care of our veterans, and these networks are extremely important in doing that. So I guess the next question I have is, I'm glad to see the Optum, which is our provider where I live, achieved a claims processing rate of under 12 days as of last month. Once Optum has paid the network provider for care delivered to a veteran, how long does it take Optum to get paid from the VA?
Thank you for that question. Right now, we're actually getting paid in 5.8 days from the VA.
So the system, as I hear it, and we're here, and I know everybody up here has heard problems with it, but I want to pass along to you all that overall, and that's what we're here to work out those problems that we've heard here and other places, but overall, I agree with General Bergman, the satisfaction's up. I hear it where I travel. I travel all over the country at various VAs. I know my own VA at home. I've heard that very same thing at Mountain Home VA. And so something we're doing is correct. And Dr. Matthews, next question for you is, does the VA assess veteran satisfaction with and trust in VA's community care program specifically, or just regard to the VA health care in general?
We actually do both. It's a longer written survey by mail for community care trust only, so we're updating the more electronic surveys to get more real-time data as we speak.
But what, if anything, do you think the rising VHA trust scores have to tell us about the rollout of the new community care program?
I would love to take full responsibility for that, but no, it's obviously wholeheartedly in the fact that we are integrating the care that we provide. As you've recognized, VA services cannot provide everything to all veterans alone. So as we integrate, as we make it more efficient, as we make it more veteran-friendly, veteran-centric, their trust increases.
If I may follow on to that, sir. you've given us the tools in the Mission Act to truly make our system unified and veteran-centric. And I think it's as we use those tools and Dr. Matthews' leadership in the modernization of community care that we're seeing that trust grow in both areas. I will just note that in addition to our surveys, what we've been proud to see is that, for instance, in a VFW survey this year, 90% of veterans said they would recommend VA to other veterans. That kind of external validation is what we're proudest to see, and we expect that to continue to grow as we continue to modernize.
And I think it's actually opened up more appointments. The VA's actually seeing more patients inside the VA. Now the Mission Act has been, am I correct on that?
Yes, sir, 2,100 more a day.
Okay, thank you. I yield back, Mr. Chairman.
Thank you very much, Dr. Rowe. I'll now recognize Mr. Bost for 5 minutes.
Thank you, Mr. Chairman. Dr. Matthews, the eligibility criteria that was the VA established was set specific drive times and wait times. Those criteria are different from the criteria that have been in the contract for Optum. This, strikes me as might be a problem on down the future. Can you explain why it was that you used rationale for doing that?
Sure, sir. Thank you so much for that question. The eligibility standards set under Mission were VA's promise about access, yes. However, in translating that to a contractual scenario in building a network, we do not want to build waste into a network. In building a network to a set of standards where we're not actually looking at the care or the services that we actually need to purchase, you're possibly contracting with providers, putting them through a credentialing process that isn't necessary because there's not necessarily care that we could refer to them. So we will be building the standard based on veteran utilization, looking at the eligibility criteria, looking at how care is needed in each individual catchment area. And both of our partners have committed to that sort of really demand sizing. It's based on demand.
So just to follow up, Tri-West would be different than Optum, right?
Actually, every catchment area, every market is technically different, as there's different sets of services that may be needed.
Okay, same Dr. Matthews as well. One of the major new aspects of the Mission Act was to allow for veterans to receive care from urgent care facilities. As part of this, veterans are expected to pay a copay depending on the number of visits and what priority groups they're in. Does the VA know how many veterans have had to pay copays and which priority groups those veterans are assigned to?
Yes, we do, and I apologize, I don't have that entire set of data memorized. I can definitely take that for the
You
record
get that
and
back?
share that.
That'd be great, thank
Definitely.
you. General Haro, say that correctly? I understand there's been a 10% increase in providers in Region 1 since December, and that you expect that growth to increase. Is that the level of growth you expect to see in all areas implementation moving forward?
Thank you, sir, for that question. We are continually looking at the data, and as the referral data shows us where we may need to add different providers with different specialties, we're committed to do that. And so if you look at just in Region 1, we have added over 20,000 more providers. We've added 44,000 care sites. And we're not finished yet, because I really do believe as this system continues to work well, we'll have veterans using it, both the VA and the community care, and we'll need to continue to respond and have an agile and robust network.
What kind of growth have you seen in Region 2 or Tri-West? Same? Similar?
On the Tri-West side, where we'll be serving Region 4, we're taking an approach where we've sat down with each of the facilities to map out demand so that we can understand how to tailor the network, and we're constructing against what that will look like. Montana and Eastern Colorado go live on April 7th. And we think because we've been at this for a while, that approach should put us in pretty good stead, because our responsibility, as Chairwoman Brownlee stated, was to make sure that we learn from the things that we've been through, because we did precede Optum, and make sure that this is as stable as we can possibly make it. So we're tailoring the networks to what we believe the demand's going to look like.
And in Region 2, we have built over 120-something thousand providers. We're continuing to build in that network as well, and we're using the same data-driven approach.
Okay. Well, I want to thank you all for being here today, and I know there's bugs to work out. There always is. But I think we're headed in the right direction, and I look forward to the next hearings we have later on when the chairman sets those up. With that, I yield back.
Thank you, sir.
Thank you. I'll now recognize Mr. Barr for 5 minutes.
Thank you, Mr. Chairman, and thanks for holding this hearing. And obviously, the rollout of the Mission Act has been widely watched by veterans across the country, certainly in my congressional district. Thank you to former Chairman Miller for your efforts in kind of laying the groundwork with the Choice program. And I don't think we would be here without, I would echo our current ranking member, and we wouldn't be here without those first steps. But as the former chairman knows, and as Dr. Rowe knows, we did have problems with provider payments under the Choice Act, and confusion over the different authorizations and difficulties with referrals made the Missions Act passage a necessity. To all our panelists here today, thank you for the work that you do to serve our veterans. And let me start with an anecdote from one of my constituents. I represented a veteran who had difficulty using the Choice program. He experienced significant delays in obtaining community appointments for cardiology and neurology. And the finger pointing that Mr. Golnick described is precisely the problem with the referral system that my constituent experienced. He was told by the VA that his case was referred to the TPA, but when he didn't hear from anyone, he contacted the TPA, who then told him they did not have his medical records. When he called the VA back, there was some confusion, but ultimately we were able to help him and discover that the delays were due to a failure by his VA primary physicians to submit his consults to the third-party administrator. Meanwhile, precious time had passed, delaying care longer than if we think my constituent had just stuck with the VA and not even attempted to use the Choice program. And so we hope that as we transition to Mission, that kind of a scenario would never happen to my constituent or any other veteran. And so I'll start with Dr. Matthews. How confident are you that as we transition away from Choice and into the post-Mission Act world, that scenario that affected the veteran that I represent will never happen again?
If you don't mind, I'll actually defer to my colleague. We actually do have an approach to this issue.
Yes, sir. And if you would be willing to share that veteran's information with us, I'd like to make sure that that care has been delivered now and that that veteran has everything he or she needs. The approach we're taking to this, and as I mentioned earlier, we are delivering urgent referrals within 2 days. We're actually at 1.4, and that number continues to improve. That's better than the private sector, and we're proud of that. Where we have work to do is in routine referrals. And this has been traditionally a fragmented and antiquated process with the technology underlying it that has been also antiquated. What we are bringing ourselves to is in line with industry best practice, which is we are standing up referral coordination teams, wholesale transforming our process. And when a veteran leaves that primary care visit, you have 2 primary care clinicians here, when that veteran leaves a primary care visit or sees us via telehealth, immediately there's a team to engage that veteran and make sure they know the next step in their care, that care is referred, processed, and that care is delivered. Our goal is to have all of these teams in place in every specialty by July of this year, and our goal is 3 business days or less for the processing.
Great, thank you, and we will double check. I think that our veterans' issues were dealt with, and he did get the care, but we'll circle back to make sure, and I appreciate the offer.
Thank you.
General Horojo, as Region 2 in my district transitions from Tri-West to Optum, ensuring an easy transition for the veterans I represent is a chief priority. As far as providers go, can you describe how you are deciding who to bring into the Optum network if the current United Health network does not meet access standards?
Thank you, sir, for that question. So the first is to look at the 1.3 million providers that we have across United. We also then look at the data on capabilities that we may need to bring in. We get a preferred provider list from the VA on those preferred providers that either the VAMC is used to using or Veterans High Referral Rate. They give those to us. We then reach out to those providers, and then we've also had members of Congress recommend different providers. We look at the big academic universities to bring those in as well.
Yeah, that's great, because I know the University of Kentucky Health System currently has a great relationship with the Lexington VA. They even share a medical bridge between the buildings, and we hope that you would be looking at facilities like these to incorporate in the network.
And yes, sir, we are.
Great, very good. And also, are you working with Tri-West to see what facilities have been seeing high volumes of veterans under their contract?
Yes, sir. We have weekly meetings with Tri-West and with the VA and really look at the referral patterns, lessons learned, and so we're working very, very closely with our teams.
Great, thanks so much. And again, I think we're making a lot of progress with the Mission Act. I appreciate all of your participation and implementation. Thank you. I yield back.
Thank you, sir.
Thank you. We will attempt to do a second round of questioning here. We're going to bump up against some votes at a point in time, but we appreciate your patience and hopefully answer a few more questions here before we have to head upstairs to vote. One question I have, I just want to follow up, Mr. McIntyre, on the issue of outstanding claims. You mentioned that late last year, systems were jammed up. There was a backlog of several 100,000 claims. You've been working through that. Can you just tell me where that stands, especially as it refers to Region 1, and as I hear from providers that say they have legacy claims with Tri-West, what we should do to work through those?
You bet. Thank you for the question, Mr. Chairman. Earlier in the hearing, Dr. Matthews talked about the fact that the fee schedule update that we get every year was very late in coming out. The VA has made changes to make sure that that doesn't happen again, which is a good thing, and she's to be commended for that. But we ended up with 400,000 claims getting backed up because they have to be stopped while the payment updates go into place. And as Dr. Matthews said, the file wasn't even in very good shape when it came across. So it took longer still to get it taken care of. The day after Thanksgiving, which is when the VA and I started working on this, along with our teams, there were 400,000 claims in a queue that were stopped. We did a prognostication and found that it would probably be the middle of the year before we would be done, and we decided that that was unacceptable between us, and we will finish the burning down of that 400,000 by next week. And we put all the chiropractors, the home health providers, others for which the margins are very narrow, we put them in the front of the list, and those are on the way out the door, and then we're filing the invoices with VA to get reimbursed for the money that we will have paid out of our own pocket.
Okay. I want to ask a question for the VA about alternative treatments. I've met with 10 constituents recently in my district that talked about their experiences with acupuncture to treat chronic pain and PTSD. And they, to a person, had all surprised themselves with how this was improving their quality of life, their day-to-day. It was allowing them to lead a full life without having to take pain medication. Potentially some some savings for us within the system too. So I'm wondering about some information that we received on caps on the number of authorized visits for certain services, including acupuncture. Do you have any more information about that? We'd requested that a while ago, and if you don't have it now, can we follow up and get the detail on that? I'm concerned about there being new caps in place that will reduce the number of visits that these individuals can receive.
It's a great question and one I can definitely clarify, as well as assure that our teams get you the answer in writing. There's a differentiation that we make within alternative care. You could have acupuncture or even yoga, massage therapy for the actual treatment of a condition. So it's actually prescribed to take care of pain or some other modality versus our whole health and wellness packages. Acupuncture, yoga could actually fall into both. So currently, as I was describing earlier, the standard episodes of care do have limitations on number of visits. However, if for treatment purposes, as opposed to whole health, you need additional authorization, the requesting provider can get in touch with VA and we will authorize more care. There is not a maximum, there is not a final when it is for treatment of conditions. For whole health, we do have limitations per year, and that is really just in order to curtail and not necessarily have overutilization, but it is a quite high rate. For instance, for yoga, we approve 30 classes a year. That's more than one a month. That's 2 a month. That's it for wholeness, again, not for treatment of actual conditions. And that's really just to make sure that we can circumscribe the usage of services. But for treatment, again, with an additional referral request, that veteran can continue the services.
Okay, I think we might need to get some additional information out to providers and help clarify that issue, so maybe we can work with you on that.
Definitely.
I'll recognize Dr. Dunn for 5 minutes if he has questions.
Thank you, Mr. Chairman. I'm glad we had a second bite at the apple. And I'm not sure who's the best person to answer this question, but if a veteran needs a certain provider who is not a member of the provider network in their area, what happens? Is that honored, or is there a way to get there, or no?
I'll go ahead
General?
and start with that, and then anybody else can chime in. So we are in regular dialogue, and so if there are veterans that have a preference of a provider and they're not in our network, we do assess if they meet the quality standards and work very hard to get that veteran in. We've also made a commitment, the 3 of us, that if there is a veteran that is already receiving treatment and we're getting ready to change from one TPA to another, that veteran gets to continue with that episode of care.
So while we've got the general here in line, can you clarify once and for all on the record, is it possible to be a provider to VA in Optum and not United?
They, yes, absolutely.
Okay, so you could be United and VA.
Our network draws upon.
I just wanted you to say it publicly.
Publicly, we welcome anybody that meets the high-quality standards to be able to serve our veterans, absolutely.
Thank you. And Dr. Matthews, there was some talk about a national nurse line. Is that going to happen?
We have actually some longstanding plans to develop what we call clinical contact centers. It's not in our immediate future just because that's a pretty large, expansive project. But Jen, I don't know if...
Enough nurses for a whole country.
Yes, thank you. And actually in the VA Sunshine Network, this has launched, so we do have tele-urgent care. What that means is when a veteran contacts us in that contact center, and we're working to bring this across the country, which will take us a bit of time, what that means is when a veteran contacts us, we can actually spin up a video visit with a single link to that person's mobile device in their home, in their living room, and get that care met without them even having to move. That's what we're aiming to bring across the country. And so, yes, modeling after DHA, which has an excellent nurse call line, we're aiming to bring these into regional areas and bring in the telehealth capability.
Thank you very much, Mr. Chairman. I yield back.
Chairwoman Brownlee, you're recognized.
Thank you, Mr. Chairman. So, Dr. Matthews, I wanted to go back to our trip to the Dakotas, and I think we both learned a lot on that trip, and hearing from tribal leaders and trying to better understand the unique needs and experience of our Native veterans. And certainly we heard a lot of challenges around coordination of care, between the VA and Indian Health Services and the community. So I was just wondering, based on that visit, is there anything that you're planning on working on to help improve that coordination of community care for these veterans?
Thank you, Chairwoman.
Yeah.
I'm so glad you asked. Actually, yes, I'm actually putting together a proposal to our executive in charge about some different steps. I will definitely share those details with you. Also been meeting with the Office of Rural Health about the MOU, giving them some feedback from our trip, trying to put a lot more teeth into the effort, as well as take into account local MOUs and bridging those communication divides that we even saw that were bridged while we were together in South Dakota. So yes, taking a lot of steps. Don't want to get too ahead of my leadership before I can share them publicly, but I can definitely share as we move forward. Just of note, I actually do have a listening session with IHS and tribes tomorrow at the Capitol Hilton. Also scheduled for a tribal consultation in San Francisco later next month. I'm very excited about the progress.
Very good. Thank you. Thank you very much. I'll look forward to hearing and hearing about what you are doing, and hopefully you'll keep me abreast of that as well. So, Dr. McIntyre, Mr. McIntyre, I'll go back to asking you the question that I didn't have enough time for before. Just again, with a big increase of mental health services within the community, I just want to make sure that those veterans are getting, those wraparound services, things like, homelessness, issues around, housing for veterans, issues around education for veterans, issues around job opportunities for veterans. I'm concerned that maybe the physician in the community is not going to be aware of some of those programs, and just wondering if you're making that connection.
So when the referral comes to us, it comes from VA. And so our expectation would be that the VA is looking at what are the needs of that individual as that referral comes our direction. And also, what state are those veterans in, right? Are they red on the threat scale, or are they green on the threat scale, right? So that we can make sure that things are properly triaged. My feeling in this space is that we're probably all a little bit ahead of ourselves in terms of how the demand has gone up for care that needs to move into the community in order to be able to meet the standards that were required under mission. We, on our end, as a company, have stepped back at a senior leadership level to say, do we want to change the model even for how we're doing the appointing support in the mental health space? And we're assessing that at the moment. We're going to sit down with the VA in our communities and say, does the model that we're thinking about going to put us in a better space? Because you've really got to have a circular loop that you can tie people back into, both within the VA itself, but when people move into the community. And we'll leverage likely some of the work that we do supporting the Defense Department services, Marine Corps and others in the space of threat, and tie people together with VA through that lens.
Very good. And just to General Horoho and Mr. McIntyre, just in terms of training for mental health, how is that deployed?
Thank you, Chairwoman Brownlee. We use Psych Armor as one of our training modules that are online, very robust of understanding the culture of the veteran, behavioral health, sexual assault, military-related sexual assault. And so those training modules are all online at the portal where our physicians can access that. We also draw upon, we have over 66,000 behavioral health providers that that we're tapping into in our network, so that we're very robust there. And then the other area that I think when you talk about behavioral health, there's a close relationship between substance abuse. And so we have MAT centers, 30 minutes drive with all of our veterans in the area. So trying to link all those together.
Thank you very much.
Similar strategy on our end.
I have to yield back because I'm running out of time.
I'll recognize Mr. Bergman for 5 minutes.
Well, it's not going to take 5 minutes. Mr. Dombey, would you tell me how long on the average it's taking to get the credentials for your providers?
Providers are reporting to us that it's been taking several months, and it's not just credentialing. You start with a contracting approach, then you get into credentialing, then you get loaded, not in the New Year's Eve sense, but you get put into the system. The word loaded came out from Optum, so it's taking months to get there.
Okay, so, General Horoho and Mr. McIntyre, does your organization have timeliness goals for credentialing a provider? And if so, what is, do you have numbers on the actual rate? Because we're trying to match up. Are we doing too much of reinventing the wheel when it comes to credentialing? I mean, what's changed? What's the same? What can we carry over? How can we match up but not waste time?
Okay, I'll go. I'll start, I'll use the example of home health if I could. So when we look at home health, which is extremely important, and there's actually extended care. So we've already contracted and loaded and have available over 6,100 providers to provide care in that area. And when we talk about, and Bill and I had this conversation outside, there are providers that are still in the system, waiting to be loaded into our system and then available. Majority of those are all in Region 3, where we have not gone live and we won't go live for several months. They will be in the system. So one of them, Amedisys, which we have contracted, they will be fully available at the end of March, and we're not even going to be live in Region 3 by the end of March. And so some of that long system is more of, as we've rolled this out in a phased manner, we made sure that we had those that we needed to be available for the areas that we were implementing at that time.
To Optum's credit, once we got into conversation, resources were committed to bringing these home health agencies and other home care providers in there. I mean, there are thousands of providers out there for services, but we have absolutely seen improvement in the process. It's been employed by Optum in that regard. We kind of set a goal, or at least I did, that we wouldn't hear from any veteran at Christmas time that they couldn't get access to care. Hopefully, they all did get the access to care because Optum did step up and started bringing things forward. So maybe this was a shakedown cruise. And
Mr. McIntyre, go ahead, if you had comments here. Yeah, thank you.
We will be credentialing the network for Region 4 as we go into each one of those areas. We currently have the 700,000 some providers that we're using in a variety of different forms of credentialing depending on how they show up in the network. Dr. Dunn and I had a conversation about this yesterday about one particular practice, sir, in your area. There was a visit paid there today. They thought that they had provided us all the files. The files are coming tonight, and we'll have that done within the next 5 days.
Well, again, yeah, thank you on behalf of Dr. Dunn. We speak for each other from time to time. We never have to think about what we're going to say because we kind of got the Vulcan mind meld going here. You guys have been around a long time. I guess I'll just conclude by saying thanks for what you're already doing, and it's always a good idea to try to put yourself in that other entity's shoes back and forth to see if you really would like it to be done to you like you're doing to others. I think that's maybe the golden rule, but we can go, I believe, a long way to making sure we're sending the signal that we're moving forward as partners with the VA and with all of you providing those services. Thank you, and with that, I yield back.
Thank you, General Bergman. Would any of the members like to offer any closing comments? Well, seeing none, I want to thank all our witnesses for joining us today. I think it's clear that the only way that veterans can receive timely care in the community is through a very collaborative process among all the players involved: community providers, the VA itself, and the contractors who are hired by the VA. Community providers have much to offer our veterans, but only if they can navigate the complexities of VA's referral, authorization, and payment processes. I think we heard today that these are a work in progress and more needs to be done. So I want to thank everyone for joining us here today, particularly our community providers, Mr. Dombey, Mr. Golnick, Mr. Freeman, for joining us here. Your voice is so valuable as part of this process. Thank you to the VA contractors and VA as well for your testimony here today. And I think we all have a commitment to working together to make sure that we address some of the issues that were raised in a way that can open doors for our veterans to receive the best care possible. With that, members will have 5 legislative days to revise and extend their remarks and include any extraneous material. And without objection, the subcommittee stands adjourned.